Hello everyone in CardioMind's channel, and after a long absence after the last video of the diagnosis and triage of acute coronary syndromes, we are covering today a large topic, which is the treatment of acute coronary syndrome. I'm going to divide it on three main videos because of course it is a large topic to cover all the treatment aspects of acute coronary syndrome in one video. As we remember from the last video that the management of acute coronary syndrome depends on the clinical presentation at first, including also the ECG if the patient is having signs and or symptoms suggestive of acute coronary syndrome, to perform the ECG within 10 minutes of the first medical contact. Then we have two working diagnoses of either STEMI or non-ST elevation acute coronary syndrome. We are going for further investigations like the high sensitivity cardiac troponin, plus minus coronary angiography plus minus imaging, and then we reach a final diagnosis of either STEMI, non-STEMI, or unstable angina, or the patient is not having a cardiac disease, so it is a non-acute coronary syndrome diagnosis. In this topic of the treatment of acute coronary syndrome, we are going to cover the general lines of treatment, antithrombotic therapy, working diagnosis of STEMI and working diagnosis of non-ST elevation acute coronary syndrome, then the triple antithrombotic therapy, alternative antiplatelet strategies, and the last one, the antithrombotic therapy in patients not undergoing reperfusion. Let's start with the general lines of treatment. Just to note, an initial diagnosis of suspected STEMI carries a higher risk of immediate life-threatening complications like, of course, ventricular fibrillation if we compare it to non-ST elevation acute coronary syndrome. Accordingly, there is an indication for an emergent reperfusion strategy and direct transfer to a center with a 24/7 PCI capabilities to undergo immediate revascularization and salvaging the myocardium in jeopardy. That's why we act promptly for a patient with ST elevation in his or her ECG. But a patient presenting with an ECG without ST elevation nor its equivalent is called non-ST elevation acute coronary syndrome. But don't forget, if this patient is having ongoing ischemic symptoms, he should undergo pre-hospital triage in accordance with the same protocols for the STEMI pathway, because they also face immediate life-threatening complications including ventricular arrhythmias and sudden cardiac death. So please do not underestimate the risk in non-ST elevation acute coronary syndrome and undergo precise risk stratification that we are going to speak about in the working diagnosis of non-ST elevation acute coronary syndrome. Regarding the pre-hospital logistics of care, it is recommended that the pre-hospital management of patients with a working diagnosis of STEMI is based on regional networks in order to deliver reperfusion therapy rapidly and effectively, and so making primary PCI available to most patients as much as we can. That's why the importance of regional network in order to deliver those patients to primary PCI capable center that are able to deliver 24/7 service, meaning 24 hours per day, 7 days per week, to perform primary PCI to STEMI patients without delay. It is also recommended that if the patient is transferred from a non-PCI capable center to another PCI capable center, that they should bypass the emergency department and the CCU and transfer directly to the cath lab, because this results in significant saving in the time from first medical contact to wire crossing, and of course associated with improved survival and reduced risk of complications. And it is recommended that the emergency medical service transfer patients with suspected STEMI to a PCI capable centers bypassing non-PCI centers to avoid delay in the primary PCI and the revascularization. And a door in to door out time of less than 30 minutes is recommended to expedite reperfusion therapy. It is also recommended that ambulance team should be trained and equipped to identify ECG patterns suggestive of STEMI or any other STEMI equivalent that suggests acute coronary occlusion and administer the initial therapy, including defibrillation if needed in case of VF, and fibrinolysis if there would be a delay in the primary PCI. And it is recommended that all hospitals participating in the care of those patients with suspected STEMI should record and audit delay times in order to achieve and maintain quality targets and then improve, because you cannot improve what you cannot measure. Let's move to the general lines of treatment. Oxygen is recommended if the patient is having hypoxemia, meaning saturation less than 90%. But a big no that routine oxygen is not recommended if there is no evidence of hypoxemia and the saturation is more than 90%. The intravenous opioid should be considered to relieve pain in those patients, and sometimes a mild tranquilizer should be considered in anxious patients. But there is some dilemma regarding morphine, which may enhance vomiting and so slow down the GI absorption of antiplatelets, so decreasing their antiplatelet effects, especially the P2Y12 inhibitors. But it may also reduce myocardial and microvascular damage when given to patients with ongoing acute coronary occlusion. And it may also reduce the antiplatelet activity of Ticagrelor. That's why there is some dilemma on the benefits versus risk of morphine in acute coronary syndrome. However, co-administration with metoclopramide may negate both effects. So far, further research is needed for the use of intravenous opioids, especially morphine, in acute coronary syndrome. However, current data have not demonstrated any increase in the risk of adverse clinical outcomes due to interaction between morphine and the antiplatelet medications. So please do not warn your colleagues from using morphine. Sometimes it is essential to get some relief of the pain till we have revascularization. What about the intravenous beta blockers? Still class 2A at the time of presentation in STEMI patients undergoing primary PCI, but they should have no signs of acute heart failure, systolic blood pressure more than 120, and no other contraindications. Not all beta blockers have the same cardioprotective effect in the context of ongoing acute coronary occlusion. So far, IV metoprolol has the greatest protective effect in experimental study regarding the reduction in the risk of VF and microvascular obstruction, but long-term benefits so far are not clear, but it is preferable to use it in case of STEMI to control the heart rate till we undergo successful revascularization. But the IV beta blockers were not tested in patients with non-ST elevation acute coronary syndrome. That's why there is no recommendation for their use so far in non-ST patients. So far, there are no specific recommendations for using nitrates in acute coronary syndrome. But of course, sublingual nitrate may be helpful to relieve ischemic symptoms, but put in your mind that reduction in chest pain after nitrates is not as specific for an anginal pain because esophageal spasm may be relieved by nitrate, so it is not recommended as a diagnostic maneuver. But one of the benefits of nitrates is that complete normalization of ST elevation along with the relief of the pain after nitrate administration is suggestive of coronary spasm with or without MI. The contraindications of nitrates we should be aware of in order to avoid using them in these situations, like hypotension, marked bradycardia or tachycardia, RV infarction, known severe aortic stenosis, or using phosphodiesterase inhibitor like sildenafil within 24 hours or tadalafil within 48 hours. Of course, it is recommended that all hospitals participating in the care of high-risk patients have an available ICU or CCU equipped to provide all the aspects of care for those patients, including treatment of ischemia, severe heart failure, arrhythmias, and common comorbidities. And it is recommended that high-risk patients, including STEMI and very high-risk non-ST elevation acute coronary syndrome, have ECG monitoring for at least 24 hours. Examples: patient having arrhythmia or new ST elevation or depression, they need at least 24-hour monitoring after symptom onset. Longer monitoring may be needed if the patient is having more than one of the following criteria, like hemodynamic instability, patient presenting with major arrhythmia, ejection fraction less than 40%, failed reperfusion or PCI-related complication, and additional critical coronary stenosis of other non-culprit vessels that need revascularization as inpatient. So in this case, 24 hours monitoring is not enough. We may need 48 or more ECG monitoring. All high-risk patients with successful reperfusion and an uncomplicated clinical course, including also STEMI and very high-risk non-ST elevation acute coronary syndrome, as we mentioned, should be kept in the CCU for a minimum of 24 hours whenever possible, after which they may be moved to a step-down monitor bed or chest pain unit for additional 24 to 48 hours. And early ambulation, which means out of bed on day 1, is recommended in the majority of patients with acute coronary syndrome, and this is of course facilitated by using radial access as the major vascular access in those patients. Prolongation of bed rest and limitation of physical activity sometimes may be required in patients with large infarcts or severe complication. Otherwise, early ambulation is recommended. Then when to discharge? Selected high-risk patients can be discharged within 48 to 72 hours from the onset of acute coronary syndrome if early rehabilitation and adequate follow-up are arranged. Patients meeting those criteria can be considered as low risk and so fit for early discharge after 48 to 72 hours, like age less than 70 years, ejection fraction more than 45%, 1 or 2 vessel disease is the only finding in the coronary anatomy, successful PCI with successful revascularization, and no persistent arrhythmias. If all these criteria are applied in the patient, so he can have early discharge. Same-day transfer may be adopted in selected stable patients after successful and uneventful PCI, meaning that we transfer the patient to a local non-PCI center following his successful primary PCI, provided that the transfer is under adequate monitoring in selected patients who have no signs or symptoms of ongoing ischemia, no arrhythmias, hemodynamically stable, not requiring IV or mechanical support, and of course the patient should not be scheduled for further revascularization if all these conditions are applied, so the patient can be transferred to another local hospital. And regarding the imaging routine, echo is recommended during hospitalization to assess regional and global LV function, mechanical complications, and to exclude LV thrombus. And if echo is suboptimal or inconclusive, so cardiac MRI imaging may be considered. And don't forget that if the patient is having pre-discharge ejection fraction less than or equal 40%, re-evaluation of the ejection fraction after 6 to 12 weeks after complete revascularization and optimized medical treatment, so we assume that stunning has resolved, is recommended to assess the potential need for primary prevention ICD implantation if the ejection fraction is still less than 35%. Let's move now to the antithrombotic therapy. This table summarizes the different types of antiplatelets like aspirin, P2Y12 inhibitors, and glycoprotein 2P3A inhibitors regarding their loading doses, maintenance doses, and if there is any dose adjustment in chronic kidney disease, and the different anticoagulants like unfractionated heparin, enoxaparin, pivaridine, and Fondaparinux regarding also their doses and if there is any dose adjustments. And this nice diagram summarizes all the mechanisms of actions of different antithrombotic medications used in acute coronary syndrome. What are the specific and most recent recommendations regarding antiplatelet therapy in acute coronary syndrome? Of course, aspirin has a class 1 recommendation for all patients without contraindication, for example, severe gastritis or aspirin allergy. The initial oral loading dose is 150 to 300 milligram, or an alternative is the IV dose 75 to 250 milligram, then the maintenance dose 75 to 100 milligram once per day for long-term treatment. Pay attention that the maintenance dose is just 1 tablet, not 2 tablets of aspirin, because this is a common malpractice. Then, P2Y12 receptor inhibitor is recommended as a class 1 in addition to aspirin, given as an initial oral loading dose followed by maintenance dose for at least 12 months. This is the minimum duration of P2Y12 inhibitor in all acute coronary syndrome patients, regardless the treatment strategy, whether it is PCI, CABG, or conservative treatment, unless there is high bleeding risk. And this is decided by the Academic Research Consortium for High Bleeding Risk, which depend on presence of just 1 major criterion or 2 minor criteria which indicate high bleeding risk. In this case, we may shorten the duration of the dual antiplatelet therapy. I put here the criteria which are the major criteria and minor criteria for the high bleeding risk, and according to the presence of 1 or more of them, you can decide whether this patient is having high bleeding risk and need shortening of the DAPT duration, or we will keep on the 12 months of dual antiplatelet therapy. What is the choice for the P2Y12 inhibitor? Prasugrel is recommended in naive patients proceeding to PCI. The oral dose is 60 mg and then a maintenance of 10 mg, or 5 mg for patients aged more than or equal 75 years or body weight less than 60 kg. Then Ticagrelor is recommended irrespective of the treatment strategy, either invasive or conservative. It is 180 mg loading dose, then maintenance dose is 90 mg twice per day. But if we want to choose between them, which one to prefer? Surprisingly, Prasugrel has a class 2A recommendation to be considered in preference to Ticagrelor for acute coronary syndrome patients who proceed to PCI. Of course, a question mark will rise in our minds. Why do we choose Prasugrel in preference to Ticagrelor? There is no recommendation in the guidelines unless it is based on an evidence from clinical trials. The famous ISAR-REACT 5 trial, which was the largest head-to-head comparison of 1-year DAPT with Prasugrel versus Ticagrelor in patients with acute coronary syndrome planned for invasive evaluation in whom more than 80% underwent PCI. The result is that the Prasugrel resulted in significant reduction in the composite endpoints of death, MI, or stroke, without an increase in bleeding complication in comparison to Ticagrelor. The only limitation of this study is that it did not have enough data on the medically managed or the CABG treated patients. This explains why the previous recommendation was regarding Prasugrel choice in patients who will undergo PCI. When do we choose Clopidogrel for acute coronary syndrome? It is recommended as an alternative when Prasugrel or Ticagrelor are not available, cannot be tolerated, or contraindicated. The loading dose is 300 mg, or we can increase to 600 mg loading dose in case of primary PCI to have the onset of action after 2 hours, and then a maintenance of 75 mg once per day. Examples of the contraindication to Prasugrel or Ticagrelor are history of intracranial hemorrhage, age more than 75-year-old, use of triple antithrombotic therapy in those with an indication for oral anticoagulant therapy, use of thrombolytic therapy if the cath lab is not available within 2 hours, and pregnant patients in this case who would prefer Clopidogrel. And the class 2B, that in older acute coronary syndrome patients who are more than 70-year-old, especially if they are having high bleeding risk, Clopidogrel can be used as the P2Y12 inhibitor of choice. If the patient is scheduled for CABG, the surgeon recommends to stop the DAPT before surgery to reduce the risk of intraoperative bleeding. In this case, you should tell the surgeon to resume the DAPT after surgery as soon as possible for at least 12 months. So as we mentioned shortly, that the P2Y12 inhibitor is recommended for at least 12 months after the diagnosis of acute coronary syndrome, regardless the treatment strategy, even after CABG. And then a PPI should be assured that it is not routine, because many doctors just because the patient is taking many anti-ischemic or anti-failure treatment that we should add a proton pump inhibitor. No, it is only combined with DAPT in case of high risk of GI bleeding. For example, the patient had history of GI ulcer or hemorrhage. Anticoagulant therapy per se increase the risk of GI bleeding. Chronic non-steroidal anti-inflammatory drug or corticosteroid use. 2 or more of the following risk factors like age more than or equal 65 years, dyspepsia, gastroesophageal reflux disease, Helicobacter pylori infection, or chronic alcohol use. In this case, you are justifiable to add a PPI, otherwise don't add it to the prescription. What about the glycoprotein 2B3A inhibitors? So far, the recommendation is a class 2A only in case of evidence of no reflow or a thrombotic complication during PCI. This is called downstream therapy, as you only use them as a bailout after you find the heavy thrombus burden or a complication during intervention. But upstream therapy, which was an old practice, that if a patient is having non-STEMI while he is awaiting the catheterization, we can start glycoprotein 2B3A to reduce the thrombus burden and the burden of infarction. This is obsolete. We only use glycoprotein 2B3A inhibitors as a downstream therapy. Regarding Ticagrelor, it has just a class 2B recommendation in naive patients undergoing PCI. Why it is a weak recommendation? So far, in a meta-analysis of Champion PCI, Champion Platform, and Champion Phoenix trial, they showed that the benefit of Ticagrelor regarding major ischemic endpoints was counterbalanced by an increase in minor bleeding complication. That's why it has no significant benefit, and also its benefit regarding the ischemic endpoints was attenuated in the Champion PCI with the upfront administration of clopidogrel. And so far, the limited data for its use in combination with Ticagrelor or Prasugrel made the recommendation for Ticagrelor in the clinical practice so far is still weak. So the recommendation for the P2Y12 inhibitors is for the Prasugrel preferred to the Ticagrelor if they are not available or contraindicated, so we can use clopidogrel. A controversial issue is the pre-treatment with P2Y12 inhibitor. Should we adopt this or not? First of all, in STEMI patients, the pre-treatment may be considered in patients undergoing primary PCI strategy, as it was shown in the Atlantic trial that the STEMI patients were randomized to receive Ticagrelor loading dose either during transfer to primary PCI center, so once they are diagnosed, we give a loading dose, or immediately before angiography. And here the median difference time between the two strategies was about 31 minutes. Theoretically, you may expect that the patient who received Ticagrelor during transfer had a better outcome, but the pre-treatment strategy failed to meet the primary endpoint of improved ST segment resolution or TIMI flow before intervention with the same rates of major and minor bleeding events. This explains why the recommendation here is just class 2B. Also, in the SWID heart registry, it supported the same results of the Atlantic trial. And we should mention that Prasugrel pre-treatment was not tested in STEMI patients, only Ticagrelor. What about non-ST elevation acute coronary syndrome patient? Here the pre-treatment is also class 2B only in case that the patient will not undergo an early invasive strategy in less than 24 hours and do not have high bleeding risk. So the patient should be scheduled for late invasive strategy without high bleeding risk to give pre-treatment. In the ACCOAST trial, there was a lack of benefit with respect to ischemic outcomes with Prasugrel pre-treatment with a substantially higher bleeding risk. And here the median time from the first loading dose to the start of coronary angiography in the pre-treatment group was about 4.4 hours, but still there was no significant benefit. And another trial, which is the DUBIUS trial, it was stopped early for futility because there was no significant difference between the upstream and downstream or a P2Y12 inhibitor administration in non-ST elevation acute coronary syndrome patients, which included post non-STEMI and unstable angina who are scheduled for coronary angiography within 72 hours. This also explains why the recommendation here is also class 2B. And the big no, that you should avoid pretreatment with glycoprotein 2B3A inhibitor, as it is not recommended as an upstream. We only use it as a downstream after coronary angiography if the patient is having a complication during PCI or a heavy thrombus burden. And the routine pretreatment with P2Y12 inhibitor should be avoided in non-ST elevation acute coronary syndrome patients in whom coronary anatomy is not known and early invasive management within less than 24 hours is planned, as here the routine pretreatment would increase the bleeding risk, and if the patient is scheduled for CABG, in this case it may increase the risk of intraoperative bleeding. Let's move to the anticoagulant therapy. Of course, parenteral anticoagulation is recommended as soon as possible for all acute coronary syndrome patients at the time of diagnosis unless contraindicated. And the routine use of unfractionated heparin bolus is recommended during PCI, which is 70 to 100 units per kg. This is the anticoagulant of choice during PCI once you are deciding that you are going for PTCA or PCI. If the patient was pre-treated with subcutaneous enoxaparin, in this case you can use intravenous enoxaparin at the time of PCI. It is a class 2A recommendation because, as we know, that the crossover between unfractionated heparin and low molecular weight heparin should be avoided in acute coronary syndrome as it increases the bleeding risk. So whenever the patient was started on subcutaneous enoxaparin, continue and use IV enoxaparin during PCI. And the discontinuation of parenteral anticoagulation should be considered immediately after a successful invasive procedure. Unless the revascularization was unsuccessful, in this case, we would continue the parenteral anticoagulation till hospital discharge or at least 7 days. Regarding the use of anticoagulant in STEMI patients, enoxaparin should be considered as an alternative to unfractionated heparin in STEMI patients undergoing primary PCI, as it was shown in the ATOL trial. So the first choice is for unfractionated heparin, then an alternative is enoxaparin. Bivalirudin with a full dose post-PCI infusion should be considered also as an alternative to unfractionated heparin with no risk of heparin-induced thrombocytopenia, as it was shown in the BRIGHT 4 trial. But the big no is Fondaparinux, that should not be used in STEMI patients undergoing primary PCI, as it was shown in the OASIS 6 trial that it increased the risk of catheter thrombosis. So we only use unfractionated heparin as the first choice. Alternatives are enoxaparin or pivalirudin. Then for non-ST elevation acute coronary syndrome, if the patient is not planned for early invasive strategy within 24 hours, you can use Fondaparinux, as it was shown in the OASIS 5 trial that it reduced the bleeding risk in comparison to the other types of anticoagulants, because here you are not planning for early invasive strategy, so Fondaparinux can be used safely. And then if the patient would proceed to PCI, we can add unfractionated heparin during PCI. And for patients with non-ST elevation acute coronary syndrome in whom early invasive strategy is anticipated within 24 hours, so of course I will not use Fondaparinux. I can use enoxaparin as an alternative to unfractionated heparin. So still the unfractionated heparin is the first choice as anticoagulant in STEMI or non-ST acute coronary syndrome scheduled for PCI. Then enoxaparin, bivalirudin are alternatives. In non-ST, Fondaparinux can be used if the patient is not planned for early invasive strategy. Then this interesting diagram summarizes all the recommendations that we have mentioned regarding the anticoagulation and their choice in STEMI and non-ST elevation acute coronary syndrome. Then the routine antiplatelet treatment regarding aspirin, P2Y12 inhibitor in STEMI and non-ST. Then the choice of P2Y12 inhibitor, as we mentioned, that Prasugrel is now preferred to Ticagrelor in case of patients scheduled for PCI, and the default DAPT strategy for at least 12 months, then the continuation of aspirin beyond the first 12 months.